To everyone behave.
Okay, hi everyone. Welcome. Thank you for joining us today. I'm really excited to be here with all of you. I'm Clarinda. I live in Mumbai and I have NMO. While I tell you my story and then go about with everything else that we have planned, maybe you can start by letting me know if you're from India. Let me know in the chat. Let us know which state, and if you're from another country, then let us know which country. And also if you're a patient or caregiver and for NMO or MOGAD or what disease. We'd love to hear from you because this will help shape our Q&A as well. So I was diagnosed in 2011. I had my first episode in 2009. And when I was first diagnosed, of course, I'm sure as all of you know, it was very depressing. And I looked for some online support and I happened to find one group, but I found those conversations very depressing. And I also found culturally, because it was a US based forum, I found that it was very different because, they tend to talk very openly about their problems, whereas in India, where we hide these things and we're not as comfortable uh, speaking about them, right? So I lived I've had NMO for the last 14 years. And for 13 years, I had not met any other patient. And then I met Sumaira, who is here with us today last year. And, I was so surprised to find out that she is Bangladeshi in origin, and she not only has NMO, but she also runs a foundation for people like us with NMO and MOGAD. And suddenly it seemed like a community of people who have gone through the same thing. So Myra, I'll allow you to introduce the foundation and yourself a little bit.
Thank you, Clarinda. I have to say, I have been looking forward to this webinar for a very long time. Um, this is our first webinar for the South Asian diaspora. As someone, Clarinda said already, from Bangladeshi origin. This means a lot to me, especially because the prevalence is quite high in our community, but the dialect between us patients and doctors is so low. So this is just the beginning. My name is Sumaira. I have seronegative neuromyelitis optica. I live in Boston, Massachusetts, but my family is originally from Bangladesh and actually Myanmar. I love India too. I also have many Pakistani friends. I'm a citizen of the world. I started this foundation almost 10 years ago, 2 months after my diagnosis from my hospital bed. And similar to what Clarinda was saying, it really came out of a place of feeling so isolated and sort of desperate for connectivity and more information and hope for the future. So today we're a global nonprofit organization dedicated to raising awareness of NMOSD, MOGAD, transverse myelitis, optic neuritis, and other rare neuroimmune conditions. We are very passionate about building communities of support for patients and their caregivers. Arif and Clarinda will tell you about the community that they've built online for our community in South Asia. Um, we fund research and also advocate on behalf of patients. I love to say that we are patient-led, patient-powered, science-driven, therapy-agnostic, and diversity is a super, super, super power for us. We have 62 ambassadors from 23 countries. Our website is available in 24 languages. We have support group meetings going in 10 countries. And before I pass it back to the TSF India team, hats off to all of our ambassadors in India, Clarinda, Arif, and Sonali. In such a short time, they have accomplished so much and make us so proud. So thank you for doing this.
Thanks, Sumaira. Yeah, so as Sumaira said, after I met her, she invited me to become an ambassador for India. And for the first time, I would have to publicly embrace my condition, which took a lot of courage. But I'm glad that I did. Because now then I became I became the first India ambassador, and now we have three. We have Arif Khan, who you can see on video, and we have Sonali Tambatkar, who is on the call but not on video. Together, we've done some good work. We're trying to bring the Indian community together. We have a WhatsApp group. Arif, if you can just post the link in the chat. We have a WhatsApp group. We do monthly support group meetings, which are a safe space where patients and caregivers can come and just talk, to people who understand. We I've been working with the Ministry of Health to try and get these diseases listed on the rare disease policy, which will allow some access to government funding for patients in need. Hopefully, if that comes through. And overall, the TSF, the Sumaira Foundation website, has a really great list of resources that are very useful to patients. And Arif, if you could, or someone could post that link as well in the chat. You can learn a lot from that website about the conditions, but you can also read a lot of patient stories. And if you feel inspired, you can share your own story as well. And we'd love to hear from you. And this is our first webinar, and I'm really excited to host this. And I really cannot believe that, that now we are part of this community that feels the same things and has been through the same thing, and we're all here in this room, and that's very special for me. Before I introduce Dr. Lekha, a couple of points. So how this will go is that Dr. Lekha will begin by introducing these diseases, talking a little bit about them, giving us some information, and then we'll have plenty of time for Q&A. Feel free to post your questions in the chat throughout. We'll take them up as many as we can towards the end. We will be speaking in English, so this webinar is primarily in English, but we have a breadth of language experience here. Dr. Lekha can manage all South Indian languages, so Kannada, Tulu, Malayalam. If you feel like posting a question in one of those, she will be able to take it up and translate and answer. If you need to post in Hindi, that's fine. Arif can step in and or even Urdu. Arif can step in and translate for us. So yeah, I look forward to your participation. And now to introduce Dr. Lekha. Thank you for being here first, Dr. Lekha. It's just amazing to have you. Um, she is the director of the Center for Advanced Neurological Research and a professor in the Department of Neurology in K.S. Hegde Medical Academy, Nitya University in Mangalore. She runs the Demyelinating Disease Clinic and the Mangalore Demyelinating Disease Registry. Her registry has over 1,400 patients. She's a specialist in demyelinating diseases like NMO and MOGAD and is deeply involved in research into these diseases. She's passionate about helping underprivileged patients receive the best quality treatment at affordable rates and has supported many patients in getting access to treatment. She is also on the advisory board, the medical advisory board of the Sumaira Foundation. Once again, Dr. Lekha, welcome. And we're really happy to have you and excited to learn from you today. Over to you.
Yeah. Thank you so much, Clarinda and Arif on the Indian side and Sumaira from the US and all people involved in this great movement. It's indeed a great pleasure to speak to an audience, some of whom I recognize by name are my former patients or my current patients. And it's really good that I can give you a broad outline. I will not bore you with medical details. I have for this talk put myself in the chair of the patient rather than the doctor and come up with questions that might be most important from the patient perspective. And I'm, of course, at the end of the talk, very happy to take any questions that you may have. So can I share the screen now?
Yes, let me make you a host. 1 second. Okay, you should be able to now.
Okay. So can all see my slides?
Yes, it looks perfect.
All right. So the topic may be a little misleading in that I'm not sure that I can demystify it in a few slides, but I'll do my best. So these disorders, as Clarinda said, I'm also a member of the Medical Advisory Board of the TSF. So these terms like neuromyelitis optica spectrum disorders and MOGAD, they're both a mouthful to utter, and these are diseases which have come into the arena of demyelinating disorders just a couple of decades ago. It started off with initially doctors and patients believing that there was only one kind of white matter disease, which was multiple sclerosis. Then subsequently, it was noticed that there were some forms which were more severe than the usual multiple sclerosis, and it was possible to tease out an antibody called aquaporin 4 antibody, which was associated with a neuromyelitis optica spectrum disorder and was responsible for that severe MS-like disease. That happened maybe about 15 years ago. And now in the last decade or so, we know that there's yet another antibody-mediated disease which attacks some surface expressed myelin proteins, which are called as MOGAD. So let's talk about some of the common problems clinically, how they manifest, how there's so much of overlap between the various conditions, the difficulty in diagnosis, and then come up with some patient-centric questions. So the patient and the family often wants to know, why did it happen to me or to my child? And most often than not, they would have done some preliminary reading. They would know that terms like autoimmune disease and so on have been offered to them, which they have not clearly understood. So let me just try to explain it in a very basic manner. What is an autoimmune disease? So conditions wherein the immune system of the patient targets some component of the body and reacts against it. So in the nervous system, the NMOSD is a disease if it is associated with aquaporin 4 antibody. That particular antibody that is generated in the patient's peripheral blood attacks components of the axon, a portion basic connective tissue of the brain, which is known as an astrocyte. On the other hand, MOGAD is a disease where myelin, the coating of the nerve, is affected. So those are typical examples of an autoimmune disease. But many of you may be more familiar with other autoimmune diseases that occur in non-nervous system portions of the body, such as rheumatoid arthritis, thyroiditis, ulcerative colitis, skin condition called psoriasis. Some of you may even have family members affected with these conditions when you have been diagnosed with NMOSD or MOGAD. So these are all autoimmune conditions that we can talk about. And of course, people say serum, and you know it's just a component of the blood. The whole blood that's drawn from you will be separated out by spinning the blood in a centrifuge, and you get the serum that just contains the proteins, which also will include the antibodies that you need to test for. And then when that antibodies are positive, then you have a seropositive patient, either having an aquaporin 4 antibody, AQP4 antibody, or a MOG antibody. And there is, of course, a significant number of patients who have disease similar to seropositive conditions, but have no detectable antibodies in their serum, no known antibodies that can be detected in their serum. So these are some of the terms I hope that I could familiarize you with. To understand, going back to the basics, if you look at the myelin on the left-hand side of the screen, it's like a newspaper tightly wrapped around a tube, layers and layers of myelin, and the tube is the axon, the actual nerve, and the myelin is like a protective coating, like an insulation of an electric wire, for example. It enables very quick and fast conduction of nerve impulses which enables every part of your brain to work. So when the myelin is primarily damaged, or there is a disease that causes axonal damage, that is when the normal function of the brain gets disrupted, and then you manifest with disease in the areas where it has caused a damage. And I'll give you examples. So we talked about aquaporin 4 antibody, which targets the axon. It directly targets the axon. While myelin, the myelin protein called MOG, myelin oligodendrocyte protein, is a surface expressing protein on the myelin, each layer of myelin. And that gets targeted by the circulating antibody, which causes loss of myelin wrapped around the axon. And so that is a typical example of another autoimmune disease. And you might ask, how did this manifest? So now, if you look at the nervous system, you have the brain, you have the brain stem, you have the cerebellum, a little cauliflower-like structure situated at the back of the head, and then you have your spinal cord extending all the way down up to the base of your low back. And it could affect anywhere in the system, where whatever the disease, whether it is NMOSD, whether it's MOGAD, whether it is MS, it tends to target the same tissue, same nervous tissue. So if you have an optic nerve myelin loss or an optic nerve axonal loss, you can have visual loss, which depending on the underlying condition can be acute, catastrophic, and produce residual damage, or despite having significant visual loss, may improve very well with immediate treatment. So that is optic nerve involvement. If you have a brain functions lost diffusely, as it can happen in some forms of demyelinating disorders in children, they can have altered sensorium, they can become unconscious, they can have seizures, they can have speech disturbances and focal weakness. That's one form of involvement of the nervous system. So if you have brain stem involvement, the stem of the brain literally, or the cerebellar involvement, you could have difficulty with gait, with balance, with double vision, difficulty in swallowing, and so on. So depending upon which part is affected specifically by the disease process in that given attack, that is how they would manifest. It does not mean that every person has to have all of this disease. It may be just one single site involved and once only, or it may be multiple attacks over time, which may or may not involve all these regions that I spoke to you about. So if it's spinal cord alone that gets involved, then that is what is called as myelitis. We refer to as transverse myelitis, wherein you have acute onset progressive weakness, depending upon where the spinal cord is involved. If the spinal cord is involved in the neck, you're going to have weakness of upper limbs as well as lower limbs, with sensory loss, with bladder dysfunction, and so on. But if it's in the below the cervical cord, if it's somewhere in the thorax, then you would get weakness of both lower limbs, paraparesis, along with all the other symptoms we spoke about. So acute myelitis is a form of demyelination that would affect the spinal cord. And as I said, you can have just a single attack of optic nerve involvement with visual loss, never to have any more attacks, or you can have multiple attacks over time when it becomes a relapsing form of the disease, whether it is relapsing MOGAD, relapsing aquaporin 4 antibody-associated NMOSD, or relapsing seronegative disease. And each of them have to be targeted specifically based on a variety of parameters, which we'll briefly discuss. So the main problem is that, as I said earlier, these three conditions, multiple sclerosis, NMOSD, MOGAD, and then of course the seronegative conditions, can all present similarly with overlapping clinical symptoms, you know. So the doctor who sees you at the beginning will have to do a set of investigations, which, as you know, those of you who have had this problem will know they have to have an MRI with a contrast injected. They have to go through a lumbar puncture, which is a spinal tap for removing of cerebrospinal fluid. and they have to go through a variety of blood tests. And I'm just mentioning the specific blood tests that we need to do, which are for aquaporin 4 IgG and MOG IgG, which gives you an idea if this disease is one or the other. And then CSF is a very, very vital source of testing, and you can't do it too many times. So most of the time it has to be handled carefully. And apart from the routine test done, we look for oligoclonal bands, which are bands of protein, which are specifically produced within the brain. And that's very specific for the diagnosis of MS. So ultimately, the doctor who sees you will have a plethora of differential diagnoses to choose from. It could be NMOSD, wherein they have had more than one attack in specified areas of the brain, like I showed you earlier. They might have a single attack of acute transverse myelitis, or it might be ADEM, the condition I mentioned that happens in children with altered sensorium. It may just be a standalone optic neuritis, or it may be recurrence of the same optic neuritis. It may be MOGAD, which could have any of these as manifestations of the disease. And then, of course, you have MS that you need to be very, very sure that you have successfully separated out through the clinical nature of the clinical attacks, the MRI picture, the presence of the oligoclonal band. So that's all left to the physician who has to sort these issues out. Unfortunately, in a setting like India, we have around 3,000 neurologists and we have 1.4 billion people. So not everybody gets to see a specialist. Not everybody will get to see a neuroimmunology specialist. And therefore, depending upon the site of involvement and the age of the child, age of the patient, more often than not, it will end up with a general specialist. So it could be, an ophthalmologist who sees you for your visual loss, or for your pediatric optic neuritis, or for your ADEM. It could sometimes even be a surgeon who sees you because the patient is brought in with a very significant paraplegia, and surgical causes are considered first in the list. And I've had patients who have been redirected back to me from the neurosurgeon. And sometimes, some of you may also have experienced this. Patients have intractable hiccups, vomiting, abdominal discomfort prior to the onset of these diseases. And very often it's mistaken to be gastroenterological problem, and I have had patients coming to me from the gastroenterologist. So therefore, we still have difficulty in clinically recognizing. The primary care physicians are beginning to be sensitized to this issue. But ultimately, what happens is that in a setting like us, we have a delay in onset of treatment because of the delay in diagnosis. That is a great challenge. And I, sitting in a registry, being a specialist neurologist, do not have the comfort of seeing a patient with the first attack. More often than not, they come to me after recurrent attacks, or they have come to me after they have developed residual neurological dysfunction, which is a shame, because that vital first attack and intervention brings out the best results, So unlike MS, all these disorders are very well controlled if you can prevent the attacks from coming, because all the disability that accumulates is from the attack. Each time an attack occurs, if it has not been diagnosed quickly and treated well, the patient adds on disability. So if you can diagnose early, prevent further attacks, then you are as good as living a good life. That is a great difference between these antibody-mediated disorders and MS. For a person already diagnosed, if I'm sitting in the chair of my patient, there should be a little bit of healthy skepticism. So when a person who has been doing so well, has never been to a hospital, never been hospitalized, suddenly has loss of vision or inability to use his or her limbs, it's a very, very frightening experience. And so there's so much of doubt and confusion. And one of the things that come up to your mind is that, have I been diagnosed properly? Is my diagnosis right? It's good to ask those questions. And it's good also to discuss it with your immediate family and get reassurance and understand whether you need any more things to be done to clear those doubts. Treatment, have I been treated appropriately? That again is an important question because what you're treated with during the acute phase of the attack is very, very important. How well were you treated in order to be able to get clear of that attack of neurological dysfunction? Later on, depending upon the kind of disease you have, you may or may not need to be on long-term treatment. So those decisions, have they been made right? That's an important thing to know. When do I know that it's not working? So this is so important because many times the decision to course correct or change medications sometimes lags behind. And that is not good to continue on a medication that is clearly not working for the patient. And I, working as a tertiary referral, setup, I often find that that is something that we should be very careful about. So if your disease is not doing quite well as you would like it to be, despite having medication, you should seriously address it. So the question would be, should my medication be changed? Should the dose be increased? Should I be on a combination? These are things that have to be discussed with your doctor. And he or she should initiate that discussion. How long should I take treatment? Now, this is it's a very difficult thing to convince a patient that sometimes the treatment may be indefinite. That's a nice way of saying lifelong. And most patients are not willing to accept that they need to be on long-term therapy, and everybody wants to be well with short courses of treatment. And I try explaining again and again that when you have a breakthrough relapse while on a good medication, because you discontinued your medicine, the outcome is never pleasant and never good. So it's good that you will, Indian patients definitely, they do not want to be on long-term medication. That's a great challenge for me because I run a registry with long-term care of patients, and convincing a patient to remain compliant is a big challenge. Short and long-term treatment effects have to be discussed, and safety in pregnancy, safety, whether it is a safe drug for breastfeeding, all these are issues that you should, sitting in your patient chair, discuss with your doctor, or your relatives should have discussed it, if not in the first visit, maybe on a second visit after a scheduled consultation time. All this should be discussed with the doctor. So I would like to talk about recurrent worsening disease, because if you have a doubt, it needs really strong attention. And I would say push this need towards the doctor so that he or she will pay attention. So before that, you should find out, the patient may not be willing to be forthcoming about compliance, but the relative should double check, triple check whether the patient has taken the medication. If the patient is not supervised, whether drugs have been missed, skipped. That all happens very often, much oftener than you think. So despite compliance, have you developed new symptoms in places that were not previously affected? That's an important thing. Supposing you never had any visual disturbance, but you've had weakness in legs, and now you're developing pain in the eye, a mild headache, and you feel your vision is blurring, that is definitely a new symptom that should be given serious consideration. So have you developed disabling symptoms in pre-existing sites of involvement? That's also known to happen. For example, if you're working very well, you could climb upstairs without support and your speed was good, and suddenly you find there is a heaviness, there is a lag, there is a need for support that you didn't need a few days or weeks ago. That seriously warrants examination and consultation with your doctor. So if none of these are there and a patient has been spoken to by the doctor and these things have been ruled out, then the thing to ask is, are you sleeping well? Are you fatigued? Are you in pain? These are the things the doctor would like to know, because these may be, indirectly causing some of this perceived deterioration in your clinical features. And those also need to be taken into consideration and treated and addressed. So identifying stressors in your work, home environment, these are questions that a doctor would need to probe into to sort out this issue of perceived recent weakness. I gave it a lot of importance because, as I told you, these are disorders wherein the main goal is to prevent attacks from occurring. So that is very important to even understand that there is an attack looming. That's the kind of importance you should give. Treatment, important to discuss treatment strategies. The first thing I will ask a patient, because I work in a low middle income setup where most patients are middle or low income, and therefore, what can you afford? You can't put a patient on a medicine that he or she can't afford because treatments are lifelong. So do you have an insurance cover? Do they have ESI or any other platform that can help reduce the burden of treatment cost? And what is preferable? Sometimes patients are so irregular and they stay away from the family. So most relatives will say, no, infusion is better. At least we know for sure the medicine has gone in. And then 6 months later, we can just go and get him or her from her place of work or wherever and bring him or her for the infusions. That's a good way of looking at it if they can afford the infusion cost, which will generally be a little more expensive than the daily tablets. What are the side effects likely? This should be understood. Different drugs, I'll give you a broad outline. Breakthrough relapses, again, I must say, which must be treated immediately. One size does not fit all. What do I mean by that? Treatments vary depending on the underlying disease, age of the patient, gender, and comorbidities. What do I mean by those? Comorbidities are diseases which are not directly related to the underlying disease. For example, a person with MOGAD can have hypertension, can have diabetes, can have a weight issue problem, or other autoimmune disorders coexisting. So therefore, those are the comorbidities, all of which have to be tackled. A person who is a diabetic, of course, giving steroids is a big challenge because it's going to aggravate that person's underlying diabetic status. Age, the person is in a childbearing age, you need to be very careful that you do not put them on treatments which are harmful for an unexpected pregnancy, for example. So these are some of the issues that have to be taken into consideration. And treatment is indefinite for aquaporin 4 antibody-associated NMOSD. So if you have the first attack, if the doctor has checked your aquaporin 4 antibody by the commercial Euroimmune test that's available in most metropolitan cities in India, then you know for sure that you have to be on lifelong, literally lifelong therapy, because these are disorders which will invariably relapse. There may be the odd case reported which has spontaneously remitted, but that is not how it behaves generally. So you do need to treat yourself lifelong with medications and you'll remain superbly well. I have doctors, engineers, students who have been with me for so many years doing very well, complying with medication and having an absolutely good quality of life. MOGAD is a slightly, more difficult question to answer. If you have a single attack of MOGAD, you just have the acute treatment with steroids or plasma exchange or intravenous immunoglobulin, whatever suits you. And then most doctors will tend to observe you over a period of time to see whether you're having recurrent attacks. So if you have recurrent attacks of MOGAD, or if you have recurrent attacks of seronegative disease, then it does merit disease-modifying therapy. I just put up the drugs that are available in India, not realizing that I might have an international audience. I saw from the chat there are many people from outside our country. The drugs that are available that I've listed in terms of the cost, azathioprine is the cheapest. It's extremely safe in pregnancy. Breastfeeding is feasible. And mycophenolate would be my next choice, but it's unsafe in pregnancy. Rituximab infusions are great because we have generic forms of azathioprine and mycophenolate in India, which are a fraction of the cost of the original drug. And rituximab biosimilars are very, very cheap. Across the counter, rituximab infusion may be available at as high as $500 equivalent, but from a stockist, you can get the drug reduced to 1/5 of the cost. So in Indian currency, you can get rituximab infusions as cheap as 15,000 rupees for a 1 gram infusion every 6 months. It works out extremely cost effective for people who can make up the money for the next infusion over time. And it's also can be timed to be safe in pregnancy. And also vaccinations, if needed, can also be timed to be given towards the tail end of each infusion. And so therefore, it works out as a very good, effective drug, which is what I would give in a person who can afford the cost of rituximab, particularly if the disease is acroporin 4 antibody-mediated disease. Then, of course, there are other shortcuts like pulse therapy with IV steroids, immunoglobulins. You can combine any one of these oral drugs with IVIG or some steroids, or even rituximab can be combined with the oral steroids. If it does not work, if a single drug does not work, combinations can work. I did not mention any of the other drugs that are now available after FDA-approved drugs because none of them have come to India, and they are prohibitively expensive without insurance cover, even in the countries where they are available. And the likelihood of them coming to countries like ours is very, very low. Tocilizumab is one drug which is available in India, and it became very popular during the COVID pandemic, and that can be given as a last-ditch effort in patients who don't respond to any of the primary drugs, including rituximab that have been listed. I have no personal experience giving tocilizumab, but it is a very good drug, but expensive, and it needs to be given at frequent dosing. So rule number 3 is learn about your disease from reliable sources. I tell you that internet is not, because I have people waiting in my clinic, and minute I mention rituximab, the message will go to somebody and they will look it up and they come back and tell me all the side effects of rituximab. That's not the way to go about it. Patient-specific information and dedicated sites, maybe the TSF, the Kathy Jackson, MSIF. These are sites which give you, proper information about the disease. And searching for a disease expert in the region also becomes helpful through these patient-centric organizations. And you not from other patients. You don't get information from other patients who you think may have the same disease, which is not a reliable way. You can seek comfort, in discussing your illness with people who may have the same disease, but don't try to get medical information which you think is applies, applicable to you, which is not very good way to go about it, because disease severity symptoms vary among individuals. In fact, the patient may not even be having the same disease as you. So you have to be very cautious. And there are people who are very much against drugs because they have side effects. And I think there are no drugs invented, including even the simple, humble aspirin. They have side effects. So adverse effects can be anticipated, and you need to monitor your drugs carefully. And it is not a reason to stop therapy or consider alternative forms of medications, which many patients try to do. Lastly, some words of caution. In MOGAD and NMOSD, you need to prevent the attacks. That is what our entire goal is, to give the right treatment to prevent attacks, because that gives you a good and disease-free, disability-free life. Drugs given for MS can worsen potentially disease in patients with NMOSD and MOGAD. So that you must factor in when you feel your disease is not doing well with the drug the doctor is giving you. Maybe going back to him or her, there may be a discussion as to whether you should be reinvestigated to rule out any alternative condition causes for the same. Comorbidities have to be treated. Obesity, smoking, diabetes, hypertension, all can worsen the underlying autoimmune disease. So you have to take it very, very seriously. Risk of infection should be minimized in patients on immunosuppressive therapy, especially bladder is a common source of infection if you've had a bladder dysfunction in the past. So ensure that you remain treated for these conditions. And also, if necessary, use masks and so on if you are in a closed working environment. Discuss vaccination need with your doctor. Ideally, all vaccinations are best given before you start your therapies. Neurorehabilitation is extremely crucial in treatment. It helps relieve pain, disability, gives you an energy, gives you a purpose that you've done your physical exercises, and also improves overall morale. Lastly, I would say, most importantly, do not shy away from addressing and tackling stress and mood issues, because you may be having the best medicine, you may be doing well, but you are not able to appreciate that you are doing well if your mind is also not, feeling good and positive about it. So always try to tackle your mood and stress issues, and be open to ventilating with people close to you or with your professionally qualified people around you. So with these, I think I will stop. I thank you for your patient listening. My email contact is here if you need to reach out to me. More than happy for you too. And I shall stop sharing, shall I? So that you can answer the questions. What do you think?
Yes, you can.
Yeah.
Thanks so much, Dr. Lekha. That was really informative.
Yeah.
I think some of our questions might already have been answered, but I have a few, and I do see a few in the chat as well. I'd like to encourage everyone who would like to ask questions. Please feel free to post them in the chat, and we will pick them up. So you did mention stress. You mentioned stress as a factor. I think that a lot of doctors do say that, it can, like, stress can trigger a new episode. Do you believe that's true? Is there any research to make that direct correlation?
So, yeah, so the immunology of stress is understood. Stress can depress your overall immunity. That is a factor, but does not mean that stress should necessarily trigger an attack. On the other hand, anything that is immune boosting will be really, really helpful to your overall general health. For example, exercise is a good immune booster. Regular meditation, yoga, all of them are really, really are helpful in that way. So to stay positive, in terms of the immunity part of it in a healthy and physiological way is really good.
Okay. And what about weather changes? Can that trigger an episode? I know that it does. The extreme weather changes can trigger some feelings, sensory feelings of, something new.
That
Do you
is
think
true.
that that's true?
Yeah. So heat is not a great help in terms of conduction of impulses in a nerve. So if you have extreme hot weather, overall the efficiency of your nerve conduction can come down. So, like for example, if you walk in a hot sun, for example, you'll find when you're walking up the steps, you walked very well the first few steps, but then later you find this exercise induced and the heat induced fatigue, and you literally have to use your hand to lift your leg up. That sort of, and even if you're exercising in the gym, for example, I always say exercise, no harm about that, but you stay in an AC environment when you're exercising so that your core temperature doesn't go up. Yes, cold can make your sensory symptoms feel more. And in fact, you may have feelings of aggravation, of numbness, and generally it gives you a sense of panic that it's coming back. That's the thing that is at the tip of everybody's mind, the mind also. I had a doctor who recently rushed down because Delhi, the weather was so cold, and she woke up feeling numb, and she was terrified of the fact that she may be having an attack. Though she herself calmed herself down and took a hot drink, rubbed her legs, put warm socks on, sat under the blanket, and she felt better. But that initial mindless panic is something that you can explain from the patient's point of view. But then when it goes down with all these measures, it is just that temperature producing that temporary dysfunction. So these are things that you need to kind of talk yourself into calming down when you have these. Yeah.
So I think that those things are real. I think that for all of us, the most real fear is this an attack, or when is the next attack? Because it's that uncertainty. So how do we separate? Like you mentioned, sometimes external factors might trigger some of these symptoms or sensations. how do we know when it's time to actually get them addressed? Because and how I mean how soon should we go and get them checked, if at all?
No, so if I ever usually when you're getting used to the new drug that has been prescribed, it might take a while for it to get effect. For example, if anybody who's listening is on mycophenolate, it takes about 3 months for the drug to kick in, and most often than not, they will be given a small dose of steroid alongside so that till the effect comes on. So when the person starts remaining on mycophenolate alone, it is not, it is possible in some people that there may be a mild breakthrough relapse, or the patient might be panicking that now I'm not on steroid anymore, I'm on standalone. So that's a situation when you feel something is not good. It's always good to visit your doctor to get that clarity. Am I experiencing something new? Should I have an imaging done? Should I have a neurological examination done? These are things that are not bad to do if you feel strongly. Because most times people will say, something is off. I never used to feel this way. Something is off. That off feeling, if you have, you should address it. You should get it checked.
Okay. Yeah. I know that many times I have that off feeling, and I'm hoping that it's not, that it will pass away. So then I'm kind of waiting it out. That's how it's been when I've had episodes in the past. But that brings me to one more question, and then I'll jump to some of the audience questions. Which is, how often, I mean, once you have a seropositive result, how often do you need to check those antibody titers? And how often, like, do you need to do MRIs in the absence of new symptoms? And is this different for seronegative patients?
No, depending on whatever the underlying condition, it's always good to visit your doctor once in 3 to 6 months. At least you need to have your bloods checked every 3 months initially, and then every 5 to 6 months at least. Mycophenolate, rituximab, azathioprine, all of them require LFT, liver functions, renal functions, hemogram, platelets, all monitored, because what it does is it helps you to pick up the early liver change or the early anemia or the early loss of count, which is the harbinger of infections and other bad things to happen. So when you monitor, the monitoring is to pick up the early signs of a drug-induced side effect. So that should be done. Most patients will do that when they come to see a doctor. So in my setup, what happens is that if the patient is doing quite well in the first 3 to 6 months, then we say, okay, get your bloods done and send it to us by WhatsApp, and we'll check your results, and then you can come and see us at the end of 1 year. When they come back to me at the end of 1 year, I would do an MRI. It's always good to do an MRI, especially in the initial few years annually. If the patient is clinically remaining well as well, it's good to have an MRI. That is maybe because I'm a registry and protocol bound, so therefore,
Right.
So
Right.
that is one of the, so antibody titers, I really, from a non-research perspective, doing MOG antibodies does not really make any sense. I'll tell you why. One is that we are using the Euroimmune test, which is a test which is done in 1 in 10 dilution standard. If you had a live assay that we are the only people in India who have cells growing MOG protein, and we can test it against patient serum. That will give you titers, any ranging from low to high titers. You can keep diluting the patient serum and testing. That is what they mean by titers. In a fixed assay, if you ask the Euroimmune guys to do a test for you, if you're doing it in 1 in 10, and then you say, okay, do it in 1 in 100 and more, each test is going to cost you separately. It comes to a huge amount, and it's not practical. So we have published recently that comparing a live assay with a fixed assay, the Euroimmune assay, for a diagnostic purpose, 1 in 10 dilution works excellently. And that's all you need to do. And depending on whether you have any clinical features or not, if you have a relapsing MOGAD or you have a standalone MOGAD, that will determine the treatment, not the titer. Aquaporin 4 antibody, once you're positive, you're going to remain positive. So you don't need to check the titers of Aquaporin 4 antibody at all.
Okay. Thank you. Thank you, Doctor. I'm going to jump to some of the audience questions and I'm going to pick some of the ones that have more relevance across. Some of you who have asked very specific questions about your own situation, it would be best if you emailed Dr. Lekha on the email address she has shared. So someone asked, how do you know if MOGAD is likely to be recurrent? Is the only way to wait for another attack? And
Yeah.
yeah. So
So that's a
maybe
very,
that's the
very
first one.
good question and the most difficult to answer because we don't have any clinical predictors as of now that we know of, which can tell you that it can recur. But some of the phenotypes tend to recur. For example, optic neuritis. Optic neuritis is a condition invariably 4 out of 5 times the likelihood of relapse is high. Having said that, would I treat the first optic neuritis with long-term treatment? That depends on how severe the optic neuritis has been. For example, a young child comes to me with bilateral optic neuritis and patient has significant residual visual loss. I'm not going to take a chance. I cannot afford for her to have another attack. So I would start her after giving her the initial acute treatment from which she will recover. I will put her on to one of those oral medications and instruct the mother. The reason I'm giving this is that we need to keep the child's vision intact and we need to be sure that she goes through school and, the rest of her life well. And then later on, we can take a call as to whether we should reduce taper. But immediately, my gut reaction is, no, I need to save her vision. I need to prevent it from recurring. So each decision is taken on a case-by-case basis. And for example, an isolated transverse myelitis of a MOGAD, I have patients who have been on 10, 12-year follow-up without a single attack after the first attack. So, that's a phenotype which may not recur. If it recurs, it will happen in the first 3 to 5 years, So you will know. And in a registry, it's really, really good that we have a rapport with the patient. They know they can call my clinical coordinator, who's an absolute gem. She's available 9 to 5, Monday to Saturday. Many of you who are my patients will know. And so they will reach out saying something is not right and we need to come. So they will come and we insensitize them with the first attack. It's all likelihood you will do well, but if you do feel anything happening, reach out quickly, come quickly. That's what we tell, and most of them do come.
Okay, thank you.
Yeah.
Is it possible to solve bladder incontinence? I know that this is a very common issue, and I think that, or at least I've found that even if your episode was not exactly like a bladder episode, it seems like there's some bladder issues that seem to be more common. It could be also just because of frequent infections. But is there any solution for that?
So most often than not, bladder is ignored during the general workup of the patient. Invariably, if you've had an attack of a brainstem involvement, or if you have had a spinal cord involvement, even if you have recovered very well from that weakness, residual bladder dysfunctions are invariably likely to be there. And what we should do, is that we should measure the bladder residual volume in the bladder. Each time you have a patient who comes to us, what we do is that we do by ultrasound. We will check the volume of urine in the bladder and then ask the patient to void and come back, and we'll check again to see whether he or she is holding urine. So if there's a significant residual volume, like say anything beyond 75 ml is residual, so that is not good because that acts like a real culture for infection. So it is best that you teach the patient, sensitize the patient, educate the patient, and say you must get your bladder emptied at least twice or thrice a day by doing self-intermittent catheterization. There's a huge resistance to the idea, but most people come around, or there will be a supportive relative who will help to facilitate this process. As you know, for males, it's much easier to introduce a catheter as it is for more than females, but keeping your bladder empty is very, very important. And you can also be on a antibiotic like nitrofurantoin, which is not a systemic antibiotic. It works for the medium of urine. So you can be on a single dose prophylactic urinary antibiotic and practice CIC. And more often than not, you do not have overflow voiding. Some people have an extremely irritable bladder. So the bladder has to be calmed down with specific medications because it will frequently contract and cause continuous voiding, very, very urgent and very frequent. That also is not bad. So bladder evaluation is a must in long-term management of these patients, and we do that all the time.
Okay, thank you. That was very helpful. Um, Someone has asked that with MOGAD, after plasma exchange, their titers aren't going down. Or are they expected to go down after, or
They said after plasma exchange, the titers didn't go down.
yes,
It went
they are
down.
the same. The titers are the same. They aren't going down.
So it generally plasma exchange removes the antibodies, and therefore the titers are expected to come down. So it all depends upon what test was used, where it was done, and all those. Generally, you're removing the antibody with the plasma exchange, so it's expected to go down. One of the reasons why you may find that patients' antibodies are negative is because they've recently had a plasma exchange. So that's a little strange, but I suppose there are exceptions to every rule.
Yeah. Okay. I'm mindful of time, Doc, and I don't want to overshoot. We just have a few minutes more. Maybe I'll just do one or two questions, I think. So we did talk about side effects. I mean, you did allude to side effects, that there are no drugs without side effects. But what are some of the most common ones that you have come across that patients need to look out for?
So azathioprine, for example, is a drug which can produce significant anemia. You should look out for that very early on. And mycophenolate, for example, can give liver dysfunction. And I've seen that with people who have been on long-term mycophenolate developing liver dysfunction. Rituximab, for example, the infusion-related reactions are more common at the time of the early infusions. Like when you get your first or second infusion, you might have some slight allergic reaction to the rituximab in the form of itching, redness, slight tachycardia, shortness of breath, because we give all our infusions under controlled environment and constant monitoring. Rituximab, there is always pre-medication, but in spite of that, some people might have that. That goes away after the first couple of hours and generally tends to happen in the first few infusions, actually. And some patients can develop a kind of delayed arthralgia about 7 to 10 days after rituximab, which again will go if you give them a very small short course of steroids. Long term with rituximab, you have to be careful that they don't have reduction in gamma globulins. Globulin levels can come down, IgG. So it's good to monitor serum IgG after the second or third dose. Most often than not, you don't end up having to supplement it, but it's good to watch out for, because if your immunoglobulins come down, then the chances of getting opportunistic infection also is high.
Okay, thank you. And one very last question. Can I pass these diseases to my children?
Yeah, I saw that question. No. These are not disorders which are genetically, in the classical way of genetic inheritance. For example, mother has it, then the child has to get it, kind of thing. But if you ask me, why did I have it? Yes, you have some inherent susceptibility in your immune system, which makes you prone to having an autoimmune disease. But that does not necessarily transfer to your child, in the way that, for example, if you have a genetic disease, mother, grandmother had it, I'll get it. That sort of linearity is not there. On the other hand, a family history of autoimmune diseases is not uncommon. For example, you might be having NMOSD, your mother might have rheumatoid arthritis, or your sister might have thyroid dysfunction. That's not uncommon. In our registry, around a quarter of patients have these disorders in their family. All of them are amenable to treatment. So there is a vulnerability that is inherited within the family, but that does not mean you should not have children or lead a normal life or have that sort of, worries. You're not going to transfer your disease to your child.
Thank you. And we're at time. Thank you so much again, Dr. Lekha.
Not
This
at
has
all.
been amazing. I'm just so happy to be here and to have learned so much from you. I know that many of you have a lot of questions that have remained unanswered. I've tried to cover some of the most common questions that all patients have. But we will follow up with an email once we publish this content. We will follow up with sending you an email with links to resources as well as Dr. Lekha's email address, which she so kindly provided. And you may feel free to email in your questions, your specific questions to her. And we look forward to doing more such events. Sumaira, if you'd like to come in.
Yeah, sure. No, a very, very thorough and easy to understand webinar. Thank you, Dr. Lekha. I'm not at all
Not at
surprised
all.
that it was such a good presentation. Clarinda, excellent moderation. Also not surprised. And I just wanted to give maybe Arif an opportunity to introduce himself to the community. Maybe, do you want to just quickly tell them about the group?
Yeah, hi, this is Arif. I am a transverse myelitis patient, and we have a community on WhatsApp called Hope. I have already posted the link in the chat box, so you can join the group.
Lovely.
And we'll share
Yeah.
the link again in the email that we send out with all this information.
A big shout out to Dr. Shamsasuddin, who's living in London, who is my patient who had come to see me from Bangladesh many years ago. I hope you're doing well, Dr. Shamsasuddin. I will write to me, please. You have my email.
Wow, that's amazing. And also, just for
Yeah.
the audience here, we have an incredible story library called Voices of NMO and Voices of MOG. We've shared, I think, about 3 stories from India. We'd love to share more. So if you're interested in sharing your story with NMO, MOG, transverse myelitis, definitely submit your story. It's on our website. You can submit it in your native language, and our website will translate it into the 24 languages that are available. So we'd love to read and share more of your stories. And again, thank you all so much, Clarinda, Arif, Sonali, congratulations. And thank you, Dr. Pandit. I will see you all very soon.
Yes.
Thank you,
Thank you.
everyone. This has been a pleasure.
Bye.
Hope to see you again soon. Bye.
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 Bye. Bye.